I would like to introduce to you Dr. Margaret Kaplan. Dr. Kaplan is an associate professor of the OT program in the College of Health-Related Professions. And what you should know is she is also a member of our executive committee, and she has really contributed mightily, attended all of these meetings, and we're so happy to have her. Thank you.
I'm an occupational therapist. How many of you know what an occupational therapist is? Oh, cool. How many have actually worked with one? Cool, excellent. So we don't have to start from zero, but occupational therapists aren't generally known historically as people who work in primary care. I think that we have a good role to play in primary care, prevention, community involvement, et cetera. But we haven't been doing that during our history as a profession. I wanted to just bring up two articles, research studies that I saw over the last couple of months that pertain to this discussion of what I'm going to call, or what I call, patient engagement. I agree with Dr. Gerard. I hate the word compliance. I feel like I'm mommy telling you must comply. And what do I feel like when mommy tells me I must do something? I don't do it, even if I wanted to do it. Before mommy and daddy tell me don't do it, I'm likely to not do it. So adherence is nicer, but for me, in my practice, engagement is what I want. I want to engage the person I'm working with as a partner. I know a lot of things, they know a lot of things about themselves and their life, and I know some other things that they don't know, and we can share that knowledge. But one of the articles that I read was a study, a large study, a national study by people at Johns Hopkins who looked at Medicare and Medicaid hospital data and 33, I think, factors in hospitals. They looked at how much money hospitals spent on different factors and then looked at readmission of patients within 30 days. And they looked at longer, but the 30-day was their main interest. And the only factor they found out of all of those factors that they looked at nationwide, where if the hospital spent more money on it, their readmission decreased, was occupational therapy discharge involvement. And, I said, "Ooh, cool, let me print that." And I got a chance to share it with you. And the article went on to talk about why might this be? And they hypothesized that I think they're totally on target, is that the occupational therapists, their focus is on the immediate functional ability of each person that they work with. Their focus is on not just their medical condition, but their functional abilities and their social environment. So with discharge, you're thinking about, can the person go home safely or back to wherever they were safely? And in our training, we automatically assume that we have to know something about the patient's social return. What's there? What's in their house? Do they have a walk-up apartment? Do they have their own room? Are there things in the environment that are going to we need to know about if this person's going home and there's some allergens and other things in the environment? Can this person stay alone all night? Is there somebody with them? And I'm going to share you. We all have family stories, right, about where healthcare went wrong somehow, and we're trying to fix those. But my mother had open heart surgery at 80, or 80 a little more, 81, and They sent her home in 3 or 4 days with my father, who was not capable of taking care of her all night, and he was had his own health issues, and she took care of him, but no one asked, oh, okay, your husband's there, fine, gone, and she was back in the hospital in 2 days with congestive heart failure. He fell asleep in the chair, she's asleep in the bedroom, she can't breathe, he can't hear her. No monitor, it was far away, and no one asked those kinds of very concrete, functional things. So you can think about how happy I was with that hospital. So this is an interesting study, and I think it's something that we as occupational therapists, we know, but I think that there's more and more information coming out that as part of a team, we want to include not just OT, but people who are going to look at physical therapy, other people who are going to look at what is present in the home, not just physically, but socially and emotionally and safety-wise. There was another article last month that I found where a group of researchers looked at the effects of, how can we help people to age in place, to safely stay at home? And there's been a lot of interest in that. And there was a study that looked at the effectiveness of a small team. They called it a capability team, and it was a team of a nurse, an occupational therapist, and a handyman. And the team visited people with complex situations, very elderly or other kinds of medical situations, people who had to use a wheelchair, people who needed assistance, et cetera. And the team visited people's homes, and they had a handyman right there who could, the OT and the nurse said, oh, well, this person is not safe getting in and out of the bathtub, shower. Yes, they have a bench. When you work in rehab, they go tub bench, check, reacher, check, and they just send you home with all this stuff that's generic. It's not made for your house or you. It's just what Medicare will pay for, and they send it home with you. They said, well, they have a bench, but they can't use it. They're not strong enough, or it doesn't fit right in the tub, or whatever. And the handyman would be able to install a bar so that the person could use their bench more safely. Those sorts of things are really simple, but they're not simple to the person who's experiencing them. Their home is their home. They don't think about changing things. And we have to be really careful about telling people that they need to change their home. I had my mother, all right, I'll use my mother again. She's sweet. She was a sweet person. And in her 80s, she had trouble getting around, and we were very worried that she would trip and fall, and my father would trip and fall, and then we'd have more problems. And, I'm an occupational therapist. I go in, I say, Mom, let's change. Let's move this over here. Let's move that over there. And she was okay. She let me move things. But I came to this little rickety table with this very breakable lamp on it. And they were both family heirlooms. Who knows who bought these things or made them? I don't know. Many, many generations ago, maybe. And there's this little rug in front of it. And came to that, and I was going to put the rug away and move the table out of the way and put a different lamp on there that wouldn't break when it fell over. And I came back, I did that, and I came back, and it was all backward where she had it. So I said, dumb, use your knowledge. So I said, gee, Mom, what happened with the plan with the table? And she didn't say anything. She appreciated my help. She didn't want to offend me, like our patients do not want to offend us by saying, no, I don't want to do that. and she didn't want to offend me. And my sister called me up and said, "What is wrong with you? Leave our mother alone." That table and that lamp was in her grandmother's house in that configuration with that rug in front of it when she was a girl. And she wants it like that. And I said, "Hey, you're right. You're right. I can't go into someone's house and say, with the best of intentions, okay, oh, I'm sorry, you need to do that, and this needs to go there, and, we need to work together." So for me, it's a question of engagement, and are we working together? And we all learn hard lessons by doing things wrong, and things don't work out. So I was not being helpful by asking my own mother to do something that she couldn't do. I could be more helpful by moving some other things and making a little more space around that rickety table and the lamp. I don't know whose, great aunt whoosie butts it's lamp, and trying to prevent some falling that might happen from that, rather than saying, let's just get rid of this. So I think that some of these studies are showing us that an OT or an OT as a consultant can train people who are working in the community for what to look for, and to bring that knowledge back to the team. I've worked with children. I've worked many years with children with disabilities and their families, and certain, you can't just say, oh, they're in a walk-up apartment, we can't give them a wheelchair while they're waiting to get another apartment, an accessible apartment, which could take 5-10 years, because some people have a way to deal with that. So they have the super who stores the wheelchair on the first floor for them safely and helps them bring the child upstairs. And then they have a smaller little chair upstairs that will fit through the doors, and they don't have to haul the wheelchair up and down the stairs. Other people have a walk-up apartment and don't have that social support in their apartment, and we cannot give them, especially a heavy or a power wheelchair, because they can't leave it safely in the lobby, and they can't get it upstairs. So, there are degrees of engagement that we need to develop, and we all make mistakes, and we get better at it. So, let me ask you. Let's say that somebody is going home, and somebody says, "Oh, they're not safe." What kind of things in the house might make it not safe, other than my mother's rickety old table? What kind of things in the house are not safe? Pets. Pets are wonderful. No, pets are wonderful for a lot of things, right? They're emotionally supportive there's lots of literature about the value of pets for people to not get depressed, helps with calming, things like that. But pets can be, people can have allergic reactions even if they didn't know they're not necessarily allergic, but they can start having, if they've got any tendency and respiratory problems, the pets could worsen it, and the pets can trip people. Being well-meaning. Dogs especially are very well-meaning, but you don't want them jumping on your 88-year-old grandmother. So pets, you got the, who would think? You're going to ask about what pets you have and how active they are? I don't know. Anything else make it not safe? Stairs. Mm-hmm.
Say that again?
Rugs.
Rugs.
Right. Yeah. So you have the people who shuffle when you have Parkinson's, but I have, and even with wall-to-wall carpeting, they get that carpeting so that it's loose. They shuffle on it hard, and the carpeting gets loose. So even when there's something, there's no loose edges or anything, sometimes you have to think about that. The other thing, and I had conversations with other people I work with on teams about, is it better to have bare wood floors or linoleum or carpeting that you might trip on? Because if you fall, it's harder if you don't have the carpeting, but you might fall more easily if there's carpet. So there are some, they sound kind of maybe not as quite important as medication and surgery, but there are things that we need to know more about. To be safe, yes, you need. Okay, and what if nobody can be there all the time? Yeah, and can we think about using technology? What?
Life alert.
Yeah.
Well, let me just say, as the daughter of a mother who now has someone there, first you have to engage them, okay? Because we weren't able to get someone in until stroke number 3. So, it's not always as easy as it seems.
Some things are easy and most things are not.
That's it.
But lighting, did somebody just say that?
Lighting.
You don't, most of you are not going to think about the lighting. It's okay, the light went out, you don't have great light at the top of the stairs. No big deal, it's okay. But people whose vision is a little less than it was, who don't see well when it's not so bright, are going to have some hard times with that. And there are these when you think about technology, talk to people. Well, what are we going to do? We have to get an electrician to put in another light. No, you can get these little stick-on things that you just touch and they light up. And so you can think about lots of things with lighting. But go back to technology. I think that, people talk a lot about telehealth, but there are lots of aspects to telehealth other than what we normally or typically talk about. Some of those things provide a check-in, a person who talks to you every day, even if they can't be there. A way for the person who's alone to be able to easily, push one button and connect with the person that they have designated, that they want to be able to call when they need to talk, not just medically, but when they need to talk. At night, as what happened with my mother, if they had a monitor in between the bedroom and the living room, they might have had a better opportunity of hearing that there was a problem and somebody waking up and doing something about it. So there are lots of forms of technology, and we need to help people to obtain them. A lot of them are not expensive. A lot of them are covered by Medicare and insurances. So I think somebody who knows those things can really be helpful on a primary care team and a discharge team, and any team that's looking to help people stay home and age in place safely. So physical barriers like stairs, rugs, things that are unsafe, even the little thing between the doorway, the little, what do they call it? Door sill. It sticks up. And you just think about your person who's not so steady on their feet, walking into the bathroom. You're going into the bathroom, you trip on that thing and you hit the tiles or the tub. No, you don't want that. So you need somebody to kind of look at all of those things. I have always worked with children, and I still do. And the stories I hear from parents of children with disabilities, and I often work with children who are on the spectrum, who require special education services, other kinds of services, OTPT, speech therapy, who have behaviors that are difficult to explain to people. Talk about needing a quarterback. These are people who have a full-time job trying to do the best for their child or their children, and also often need to keep their job, because otherwise they don't have any health insurance, and they're not saving towards retirement, and they need to keep their job. So what does the school say to them? I hear it all the time. People in the school say, oh, that parent doesn't care, they're never here in the school. They don't come to all the meetings, so they don't care. And what do you say? You hear someone say something like that, what do you say? I hear a student say that, I say, okay, stop right here. How do you know they don't care? What do they do that says they don't care? That's a judgment that you're making. Well, they don't come. Oh, well, what are some other reasons why they might not come? Oh, they might have to work during the day when you ask them. All the meetings are during the day. Oh, well, can't they take a day off and come to the OT session and the PT session and the speech therapy session? And yeah, sure, they can take a day off for all of you. And then they don't have any sick days for when their child is sick. So you reason out with people and you help them to understand other people. And what I do with parents is to say, you know, I bet you hear this, and I bet you hear that, and they say, oh, I do, and it's killing me. On top of everything else I have to do, I have to listen to people's judgments about me. And I think that one of the barriers are those emotional barriers that keep a person, like a parent of a child with a disability, from going to a specialty appointment, because they don't want to hear again what the problem is. They don't want to hear it. They can't take it. I've got all these problems. I have all these services. I don't want to hear about that one. How important is it? So how do we get somebody who's totally overwhelmed like that to go to another appointment? What do we have to do? Other than calling, reminding them, which is extremely helpful. Extremely. What do they have to feel that would make them go to that appointment? That people care and that they're not going to be judged, but also that it's important. So when we tell somebody, okay, I want you to go to the audiologist, I need to follow that up with saying, if you go to the audiologist, you might be able, and we find out there's a hearing loss, you might be able to communicate with your child better. And other people have found that when the child can hear you better, they speak more frequently. And if their child's speaking is one of their major goals, and you tie that to the audiology appointment, they are much more likely to go to the audiology appointment. I'm stating the obvious, but we sometimes forget that. We know it's important. We tell them it's important. They should go. Sometimes they don't. So research needs. We need to make sure we know what the big issues are for people that we're working with. Some of them are going to be community issues, definitely, and some are going to be just things that we get to know are things that happen commonly and we ask people about, right? Like the stairs. And we know in some areas people live in elevator buildings, but in other areas people live in walk-up buildings, et cetera. Things like social support. What activities are available in the community? We want somebody to exercise. Some people have a gym in their building, but most of us don't. So how are they going to exercise? We have to go that next step with people and figure out how are they going to exercise. And I'm gonna make a case right here for, I know people talked previously about patient navigators. I don't use the word patient because most of the children I work with are not patients, they're just kids with disability or condition, but they're really not patients most of the time. But patient navigator, or what I prefer to think of as a community health worker. And community health workers, I think, we have a big research need to see how those community health workers and somebody like an OT can work with a team to keep people safe, living at home, active as possible, happy, as social as possible. We know how important that is for physical health. But to see whether we can improve adherence, et cetera, if we know more and we have somebody who can act as that community liaison to people who are at higher risk, people who have multiple medical problems. And I could do my own little, it's not a advertisement. I don't need anything yet, but I just got a grant also, the same New York State Department of Health source, to develop my curriculum for community health work people, and to provide retraining and training for people in the community. And what these people will be are people who live in the community, people who understand their community. So I don't have to, if I don't live in a community, I have to go learn what's available. These are people who know what's available. They have to be people who have certain personality characteristics, non-judgmental, people who want to help other people, people who have had possibly their own illness experience, their own medical experience, their own disability experience, possibly, or with families, so they have some understanding of that. So these are people with personal characteristics that allow them to be helpful, and some training that we want to give in medical conditions and what to look for, red flags, et cetera. So very excited about that, and sorry I didn't have any PowerPoints, but you can just contact me and I'll remind you of anything you want to know.
Before you leave, are there questions? Comments?
On the last point where you were talking about with what you're getting ready to do, how would we, if you wanted to be involved in that, how would you go about it? You said just contact you, or?
I just got the grant, so yes, what I think what we will do, and we're looking for people who want to be trained as community health workers. We're gonna ask Dr. Straker. Yes, but we'll announce that through this network and other networks.
And the reason for this is that we're trying to make this an organized funnel. So we want to make sure we get all of the information, we're able to capture it, and that Dr. Kaplan then can get it in an organized way. So that would be the great way to do it. I want to thank Dr. Kaplan